morning, everyone, and welcome to our webinar on Digital First, Moving to Online Triage and Consultations. I'd like to welcome you all and thank you for attending today, particularly when time is a precious commodity in the current situation. Just for everyone's information, we are recording this webinar and do aim to share this tomorrow so that colleagues who couldn't be on the live version with us this evening will be able to watch. I'd like to start this webinar by introducing our presenters for the day. We're joined by Minal, who is our Deputy Director and Clinical Lead for Digital First Primary Care here at NHS England and NHS Improvement. We're also joined by Tricia, who is the Professor of Primary Care Health Sciences at the University of Oxford. And we are also joined today by Dr. Robert Barnum, who is GP and Director of Primary Care Improvement. They will be giving us short presentations before we move on in the webinar to have a GP panel discussion. During that, I'm pleased to say we are joined by two, potentially three esteemed GPs from across England, Dr. Ross Dyer-Smith from the Hurley Group, Dr. Ed Tiernan, a GP at the Humble Yard Practice, and we hope to be joined by Dr. David Trisker, who unfortunately may have been pulled into another emergency but is trying to join us later on. I'm now going to pass over to Minal.
Thank you, Natalie, and thank you very much to everyone who's joined us. It's great we've got you all on. Just before I start, we're really keen for people to ask questions, and we'll try our best to answer as many as we can throughout the webinar, but we also have a team manning the chat function who'll also try to reply to your messages individually. We'll also post all the questions and answers on our future NHS platform. Details of how to join are on the last slide of this presentation, so you'll get them at the end. And the future NHS platform has been set up as a community to share resources, a safe space to ask questions and share your experiences. And we will have a team of subject matter experts manning the platform who will be ready to help and contribute, so please do use it. So I think it's fair to say we're in the midst of the greatest crisis that our NHS has ever faced. And while general practice has always been the backbone of the health system, now more than ever our role is essential in creating strength and stability for our colleagues and the rest of the system. It is already a hugely challenging time, both professionally and personally, and resilience will need to centre within our teams, working together with our PCNs and our community services to stop the system from collapsing. Over the last couple of weeks, digitising general practice has been fast-forwarded. Online and video consultations have become a necessity and support 4 key areas for maintaining essential services during this crisis. They help us with the ability to protect our patients and staff by minimising footfall into our practices, and protect high-risk patients from travelling to reduce the risk of infection. The ability to enable practices and systems to stabilise by supporting staff who are self-isolating to contribute and work from home remotely, triaging and managing patients. The ability to tier our workload and filter out non-urgent or administrative requests and prioritise urgent clinical work. And also to change the way patients interact and use the NHS, including educating and empowering them to self-care. So just a quick recap of key messages that we've been discussing over the last couple of weeks. Practices should move to a total triage model using phone, online and video. Total triage means that every patient contacting the practice is first triaged before making an appointment, and it's possible to do this entirely by telephone, but this is likely to be less efficient, hence the combination with online solutions. Consultation should be remote unless it's absolutely clinically necessary to see somebody, and any pre-booked appointment should be converted to remote appointments. Practices and commissioners should promote online consultation services where they're already in place or rapidly procure one. if they don't have the solution. And for those that don't, we will help you get one rapidly. A rapid bundled procurement is going live tomorrow with a turnaround time of a couple of days. We have centrally managed the supply negotiation, the specifications, the contracts and the assurance to reduce burden, but also enable good practice and speed. We would expect commissioners to engage with their clinical directors and the LMCs to decide on what type of solutions you need, but we can get them to you very quickly. We will also provide hands-on capacity and support to enable you to do this at pace. One of the teams we're working with very closely is the Time for Care team, and Robert will be giving a short update on some of the plans we're putting in place in a little while. So, this is, for any commissioners on the webinar, this is the email address of our procurement hub. So if you are looking to procure a solution, you don't have something, then please do note that down and email them and they'll be able to support you. So other steps to take. Turn off online pre-bookable appointments if you are triaging all your demand, but you must be triaging all your demand. Encourage use of other online patient-facing self-serve type services, so repeat prescription ordering, patient access to medical records, and if you are turning off appointment booking, make sure you don't inadvertently turn these off. Set up appointments that have been made available for 111 for direct booking as remote appointments. And importantly, we need to start working over a wider footprint beyond just our PCN and focus on enabling staff to work across our neighbourhood, enabling record sharing and smart card access across all sites. And if you haven't done this already, this will be a vital part of maintaining local systems. So, total triage. While many practices have moved to total telephone triage, as our demand rises and our capacity falls, we will need to leverage even more efficiency and flexibility from our systems. And so we recommend using a model that combines both online and telephone in a total triage way. So what does this mean? A patient completes a structured questionnaire gathering clinically useful information for the practice in their own time. The questionnaire asks the same questions that we would do in practice, but it has the added advantage that the system doesn't forget to ask a question, and then this is then sent securely to the practice. Usually the patients can access this service from the practice website. Sometimes it may be through an app. If a patient phones the practice, then the practice staff should encourage them to use the online system. Staff can send them an SMS link to access it easily or encourage them to ask a relative or carer to help them. But if they can't or choose not to, then the reception staff can complete the online form on behalf of the patient. This way, whether you're a digital user or a non-user, you have an equitable service. And for the practice, work flows through a single route, which is both safer and more efficient. Administrative staff then filter out any admin requests, they flag any urgent requests to clinicians, and distribute work to the most appropriate person in the team. And that's not always the GP. The information is then presented to the clinician in a way that is quick and easy to assimilate, helping them decide what to do next, with 4 possible modes for resolving a request, so either an online message, a video consult, telephone, or face-to-face. And flowing them into the right care settings, so particularly with face-to-face, if they absolutely need a clinical assessment, examination, then whether it's your hot or cold hub, or in some cases red, amber, green sites. So that's particularly important at the moment. A total triage model can also be used for setting up a virtual hub. So this is where clinicians work on behalf of a group of practices, providing remote consultations, and this has been successful in maximising capabilities of staff across practices, managing overflow and maintaining stability where practices have temporarily had to close down. So Trish will be talking much more about her research on video and where it's particularly helpful. So I'm going to focus on online consultations and the benefits they add to the telephone. So, what are the additional benefits of online consultations to telephone triage? Well, firstly, the online system itself can provide the patient with information in real time. So, for example, signposting to nhs.uk, to a validated symptom checker, to self-care help and information. It can also be used to provide information about how to use online and video consultation services without the practice having to explain this over the phone. The asynchronous nature of online consultations means that the patient provides the history in their own time. So for clinicians, it's more efficient because they don't need to spend 5 or 10 minutes gathering the history, but have all the clinically relevant information they need to decide what to do next. The history is saved automatically into the notes, so you spend less time documenting. And patients can also send in photos, which helps to manage more things remotely. For patients, the evidence to date shows that patients do like this way of accessing their practice, especially if they get a reasonably fast response, and those using it report high levels of satisfaction. The research has shown that patients are often more honest online and feel more able to express themselves, not confined to the 10-minute appointment and not being interrupted by a clinician. Apparently, we interrupt within 26 seconds of somebody talking. And it's also more convenient because it's not centered around the clinician's availability. Online consultations can also facilitate communication with the practice team or the MDT, allowing faster access if decisions need to be made rapidly in this complex and particularly uncertain situation. Other benefits are that staff can filter out the admin or non-urgent clinical queries quite easily to optimize use of clinician time and ensure work is sent to the right person in the team. And you can prioritize care based on need as you have prior knowledge of what's waiting. Staff also really like it because the admin staff can use the online consultation templates as a health navigator or a triage support tool. And for clinicians, it allows flexibility, particularly in how we run our day and manage our demand. We can move requests to the right person, we can provide faster access to care for those that need it, but it also builds resilience because you can customize your appointment lengths based on what you're encountering. And I think it's really important to remember that just because we're doing it remotely now, doesn't mean that we have to do it more quickly. So we don't need to put that added pressure on ourselves. But also with a full pre-consultation history, if we are having to see somebody face-to-face, particularly right now, we can limit that face-to-face contact to an essential examination, especially those that are presenting with respiratory symptoms suspected to be COVID positive at hot sites, where that's really important. So does it exclude people? So does it disadvantage non-digital users? So looking at data from about 500,000 online consultation requests, about 50% of people complete the online consultation themselves, and 50% of people are supported by a relative or the reception staff. So a pretty equal mix of those who are digital and non-digital users. And a large review via the NIHR has shown that we as clinicians often make the wrong assumptions about who can and actually can't use the system. So assumptions about who has access to the internet were not evidenced, and assumptions about who we recommend should be using remote consultations are not evidenced. And this data shows that here lots of parents are using online consultations for their young children. In terms of the older population, you've got people in their 90s also using online consultations, so clearly there is a preference here for telephone, so there isn't a one-size-fits-all. And I think we all know in our own experience that some patients often, when they're trying to contact the practice, they're using 2 or 3 phones simultaneously to get through, whereas with online consultations, there's no bottleneck in getting through to the practice. The same NIHR review showed that online consultations can improve access for carers, for parents, those with mobility problems, patients that feel apprehensive about accessing the surgery, so some mental health issues, sensitive or embarrassing problems. They find online consultations less stressful and often are more willing to disclose information online. Those with particular information and communication needs, so hard of hearing, find it easier to use a text-based solution. and patients whose first language is not English. Now, this is always a concern, but our case studies have shown that they often prefer to be consulted via a text-based solution because they can take time to express themselves and receive help from relatives or friends at their own convenience and can take their time. But as I said, there is no one-size-fits-all, and online does not replace telephone. There will be populations who can't or are completely disinterested in using online services, but are happy to use telephone and SMS, so it's about what works and for whom. But I would stress 2 key points. Staff guiding patients who phone up through an online consultation form or having that option is really important for equity, and encouraging more people who can use online to do so can free up time on the phone for patients that can't. So this is some interesting data. So this data was pre-COVID, and as you can see, about 2/3 of GP consultations here were closed remotely, with about 1/4 closed through an online message. It's also interesting that only 24% of patients actually wanted a face-to-face appointment. So this data is from 44 practices with a list size of about 450,000 patients. If I then move on to this next slide, we can see, and this is, during COVID, so now 80% of consultations are closed remotely, with less than 10% requiring or requesting a face-to-face appointment. So we can see a real shift in the use of digital services. Of course, in these circumstances, the balance of risk has completely changed, with a trade-off between remote management versus the significant risks associated with exposure to COVID. So we will probably be managing much more right now than we would have previously through the online route. And this will feel different. For example, we'll be prescribing more antibiotics empirically, but it is accepted nationally, and NHS England encourage us as clinicians to use our professional judgment in these ambiguous circumstances. But also the GMC has issued a statement recognising that in these highly challenging circumstances, professionals may need to depart from established procedures in order to care for patients, and they support the use of our professional and clinical judgment. So how do we do this? How do we implement online consultations and total triage? So these are critical success factors that are based on learning taken from a rapid synthesis of published literature, case studies, and talking to experts, which in this case are practices that have been working in this way for quite some time. We've split them up into 4 key stages: the planning, supporting, changing, and using. These stages are outlined in more detail in the blueprint that we have published on NHS Futures and will shortly be openly available on the NHS England website. So sorry for the delay in that. For many, this will be a new way of working and making decisions, potentially using new technology, and also working in a new environment or working from home or remotely in already what is pretty hot circumstances. And so we do not expect practices to make this change without any help or capacity. And we've been working really hard with our national colleagues, regional and commissioning colleagues, AHSN, CSUs, as well as the suppliers, to identify and redeploy hands-on capacity to support you with implementing online and video consultations. So you do not have to do this alone. I'm going to go through these quite quickly before I hand over to Trish. So planning, you need to set up a small team to lead the change, flatten the hierarchy so the team doesn't need all the decisions ratified by the partners. They can work in an agile way, but of course with some clinical oversight. The practice teams may be dispersed because some people will be self-isolating. MS Teams, the Microsoft Teams, has been enabled for everyone with an NHS mail account now, so you can use that, or similar for team discussions when setting up, but you do need to have those team discussions because successful change is dependent on the culture. So do involve everybody, ensure everyone gets it, why you're doing this, champion your champions, and be clear that this is not about blaming anybody if it doesn't go quite right. It's about learning, adapting, and improving. And you will have head cover from us as a national team, your regional and system leads, your commissioners and CCIOs. You just have to do the best you can. It's also important and helpful to measure your demand against your capacity. Now, it might be slightly unpredictable right now, but a simple estimate is a good place to start to anticipate where mismatches are in your demand and capacity. You can always refine this with data coming in from your online consultation supplier once you've gone live to help you plan your services. So I'm just going to hand over to Ed for a few minutes now to talk you through the demand and capacity calculator. So Ed, over to you.
Thanks, Minal. I'm Ed Turnham. I'm a GP and I'm the clinical lead for the online consultation project in Norfolk and Waveney. In Norfolk and Waveney, we've got several practices which are using Footfall, our online consultation system, to enable a full online triage model. Common concerns from GPs and practices, which are completely valid, include: will we be completely overwhelmed with demand? Will demand increase exponentially over time as patients realise how easy it is to get access to us? And as I said, these are completely reasonable questions. And there is good data from Ask My GP, which has been doing this longer than us, and now from our own practices to show that this isn't the case. Demand is actually very predictable. To predict your demand, you don't need to do anything really complex like logging the phone calls you're having every day under the new system. The problem is it's hard to really actually identify what the true demand is under most of our systems because a lot of demand is suppressed and patients aren't able to get in. Ask My GP has found that the total number of requests that a practice will get per week is equivalent to about 6.5% of the total patient list. So if you've got a 10,000 patient practice, you'll get about 650 requests per week. And that's including what comes in online and what's filled in on behalf of the patient by receptionists for patients who can't use the online system. And we found for our practices, obviously a smaller number than for Ask My GP, actually we're finding figures of about 5 to 6% of the patient list being the number that contact the practice each week. So slightly lower, but we're measuring it in a slightly different way. So what we developed is a tool for practices that enables them to predict what will their demand be under an online triage model, where will the demand come in the week, and how can they spread out the workload across the week. So if we look at this slide here, this is an Excel spreadsheet which will be shared with you all online. Here the practice puts in the clinical sessions that they've got. So at the first line there, you've got Dr. Smith. He's in on Monday all day, so there's 2 sessions there. On a Tuesday, he's in all day, but half of the session is teaching, so he's 1.5 sessions, and so on. And you do that for the doctors, for the nurse practitioners, emergency care practitioners. What the practice then has to put in is simply its capitation. So the patient list size here, we put in 10,000. And the next figure down there is 6.0%, which is the halfway house between our figures and the Ask My GP data. That's the percentage requesting help per week. We then we compensate for things like annual leave in order to predict how many clinical sessions you'll have on average per week. At the bottom there, you can see a prediction based on Ask My GP data of what proportion of your requests you will resolve online, by phone, and by face-to-face appointment. And we should really start putting in video in there, but at the moment it's a very small proportion, but it will grow quickly. What we haven't shown on this slide is that this turns it into a prediction. Firstly, how many requests will you get per clinical session on average? And a lot of practices, including my own, have been pleasantly surprised to find that it's not sort of 20, 25 per session. In my practice, it was actually 11 or 12 per session. And this is a practice that has been struggling to meet demand, particularly for routine appointments in recent months. And so we actually find we would cope very well under a digital triage model. What we then work out is what proportion of those requests will come in on each day. So we know 30% of requests come in on a Monday. That's including everything that comes in after 6:30 p.m. on a Friday. And on the other days of the week, it's considerably lower than that, almost half as much in some cases. So we can predict what number of requests you'll get each day and what proportion each day will need to be face-to-face, phone and online. What we can then do is to think, how can we spread out the workload across the week? So almost every practice will find that Mondays are really busy under this system because you've got all that demand that's come in after 6:30 p.m. on a Friday, and now that comes in on a Monday. And the online triage model to date has been very much based around dealing with things on the same day, but this doesn't necessarily have to be the case. A lot of things can be postponed by days or even weeks in order to spread out the workload. Most practices do obviously stack their clinical sessions on a Monday, so you have more capacity on a Monday, but it's not enough. The distribution of demand is so skewed toward the Monday that almost every practice will have a really busy Monday if they try to deal with everything on the day. So what we've come up in this Excel spreadsheet is a simple suggestion for how you could postpone a set number of face-to-face appointments which are triaged on Monday but booked in later in the week. And we see that you can make your workload even across the week through doing this. That's just one way of doing it. There's other ways of doing it. Obviously, at the moment, we've got very few face-to-face consultations, so we need to be doing it in a different way, perhaps actually postponing the triage until later in the week. And that's it from me.
Back to Dr. Minal Bakhai regarding redesigning your workflow.
Thanks, Natalie. Can you hear me?
Yes, we can.
Okay, great, thank you. So next, you need to redesign your workflow with your staff and your supplier, and use the implementation team that will be supporting you and working with you. So think about continuity when you're designing your workflow. Identify cohorts of patients you think would absolutely benefit from continuity, so they can be flagged by admin staff and passed to the right member of the team. Sorry. Also make sure that you have all the equipment you need. So headsets and 2 screens are really helpful. As you saw from my earlier slide, phone calls go up, and so you need to make sure you've got enough phone lines and network bandwidth, and advice has gone out to commissioners about this to help you. Also think about contingency planning. So if the service is becoming overwhelmed, speak to your supplier about what messaging they can put up or which non-urgent functions can be temporarily disabled. Have a plan if the system crashes, for example, a website message, and switch to telephone triage. So, training. Sorry, very temperamental system. So your supplier will provide training on how to deploy and use the software. It's helpful to test out the system, so try a team simulation, get familiar with it, ask staff to submit a test online request to understand the journey from the patient's perspective. Many suppliers will also provide clinical training resources. You will need to adopt a slightly different approach when consulting online, and I will ask our panel at the end to share some of their top tips with you. You will also need to change your systems and your practice processes. So set a go-live date and turn off any pre-booking of routine appointments. Convert any already pre-booked appointments to remote appointments and let affected patients know, and remember to amend the SMS reminders for these slots. Change your appointment book, creating slots for online consultations. Clinicians will be working flexibly, so essentially the timing of these slots becomes largely irrelevant. But it's helpful to use these to pass work to different members of the team. And dedicate staff to triage, especially at peak times. So the busiest times are usually between 8 and 10 in the morning, with most of your demand coming in before lunchtime. So allocate staff accordingly and start triaging early. So the evidence shows that the best way to communicate change is in 4 ways. Place a banner prominently on your website. This will be the gateway to online consultations, and your supplier can help you do this. All approved systems will have also been asked to keep up-to-date information on COVID provided through their system, so that can also be provided for you. And it needs to have some very clear messaging about how patients should use this and what patients should use when. Use your reception staff and clinicians to encourage patients to use online consultations. So brief staff using a script, the messaging is consistent. Update your telephone answer message with a senior GP encouraging use, and also send an SMS to patients.
Yes, we can hear you back in now, Ed.
Sorry about that.
No problem. And send an SMS message to patients telling them about how to access the practice. Also encourage patients to use online prescription ordering, get them to nominate a pharmacy, and there's no need to ask patients to come in to collect their reports or their sick notes or fit notes, letters. These can be sent electronically. If some of you are using AccuRx, then that helps you send these notes through a text message or a text message link, or alternatively they can be posted. It's really important when you're communicating to make the in-hour and out-of-hour response times clear. You want to try and have a consistent front door to access your online services. Other methods of communication include social media, your PPG, patient groups. These are all really helpful. So when it comes to go live, reassess your go live date. Make sure you've got enough staff to actually go live. Have a floor walker if possible to troubleshoot. If you can, and it can be difficult, avoid a Monday morning or a Friday afternoon. Ensure everyone has a copy of the workflow and important contact numbers, your IT support and your supplier handy. And then once you've gone live, start to monitor your data and get feedback. Have daily stand-ups to start improving your processes and understanding where pain points are. So finally, from me, some top tips for online consulting. So aim to respond promptly. So the faster you can respond, the better the experience for the patient. But we are all under a lot of pressure, and sometimes it can be very difficult to respond very promptly. But if you can let a patient know that their online consultation is being reviewed, especially if it's a clinical request, even within a couple of hours of them submitting it, doesn't matter if you've not completed it, you've not responded with a clinical response, but just let them know that somebody in the team has received it and is looking at it, then it will help to avoid the patient calling up, or worse, coming to the practice because they feel like they've been ignored. It will also improve their satisfaction, and it will help pick up urgent queries more quickly. When writing a message back to patients, consider the wording of your messages and how this may be received. Often patients have spent quite a long time writing the online consultation to you, so think, how would I feel if I got this response? Be alert to written cues. You might be able to identify patients concerned with the language they use, and then that would help with your decision making on the type of modality that you use to respond back to them. Try and avoid using jargon, acronyms, use large text, keep sentences short, be clear. When you're safety netting, be specific. This is often information that patients will refer back to. But some quick wins are using links to nhs.uk that clearly outline information in patient-friendly language. They also talk about red flags for patients to watch out for. You can also send attachments. It can be helpful to use the online messaging after a call to provide a short summary outlining the key points of your conversation. Have preset templates that you can customize to save you time. Use the coding templates that have been provided by your supplier to code information quickly and easily. One really helpful thing that I particularly like about online consulting is because it's asynchronous and it's remote, if you have a dilemma, you can ask your colleagues. And actually, it improves clinician satisfaction because you have more interaction with your colleagues. So you can discuss cases before you respond back to the patient, and that also builds confidence in the responses that you're providing remotely. If a clinician knows the patient, then more often than not, the requests can be managed remotely. So try and pass requests pass patient requests to their known clinician if speed and urgency isn't an issue. But at the same time, try and avoid building up a surge of appointments later on in the day and manage whatever you can in the same session. So trying to do as much of today's work as you can. And then finally, indemnity. So this is always a worry. So the Crown Indemnity, the CNSGP, covers you for consulting online. So for any clinical negligence claims resulting in remote or online consulting, it doesn't matter what solution you're using. It doesn't matter where you're consulting from. It doesn't matter whether you're working in hours or out of hours. And it covers your whole practice team. But you still do need to maintain your indemnity with your medical defence organisation to cover you for issues that fall outside of claim. So I'm now going to hand over to Trish.
Hi, is my muted? Can you hear me?
Yes, we can hear you, Trish.
Splendid.
So I hand over to you now.
Just because I've not given one of these talks over a WebEx before. Hello, everybody. I can see my first slide, but do I move them on or do you move them on for me?
You can move them on. The button is at the top. But
yeah, no, that's fine. I wasn't sure if I've moved everybody's on or just my own. Okay, great. Well, I'm Trish Triage. I am, I suppose, an ex-GP. I was a GP for 30 years. I haven't practiced for 5 years, so I'm a little bit out of it, but I have put my hat in the ring to go back and do some of these consultations. So I need to get this right because I'm actually going to be using it. I have been doing research into video consulting for about 11 years. I went to the NIHR in 2009 and wanted some money to research video consultations, and they turned me down because they said this would never happen, which is quite extraordinary considering the place we are now. Anyway, we went back and asked them again about a year later, saying it was now government policy to offer video consultations. So they then gave us some money, and we've been doing research into video consults ever since. Mostly qualitative, but also a bit of quantitative work, acknowledging various funders, including the Health Foundation, NIHR, Wellcome Trust, and also a very strong team that work with me. Okay, so what I want to talk about today is, and in relation to COVID, when a video consultation is appropriate, because actually a phone conversation, or as Minal says, an online sort of email consultation, will be fine for probably most patients. Getting set up for video, how do you actually do a professional quality consultation by video? Fourthly, what tips are there for patients? And finally, very briefly, I've got one slide on the research evidence because I rather suspect you guys mostly want to hear how to do it rather than all the academic papers. Okay, so when are they appropriate? And this is sort of appropriate in the context of COVID, but also one of the things that we really need to remember, and I'm sure you know this, is that non-COVID consultations, some of those have to go on, even in the current crisis, because there are things that can't wait. So in the COVID group on the left, of course, if you're self-isolating yourself and you've got a connection, you can access practice records from home, for example, you can just carry on, provided you're well enough. So that's an important factor. If the patient is either a known case or might be a case, there's quite a lot of research evidence to show that the anxious patient actually responds very well to video. They do a lot of psychotherapy by video. Just seeing the face of a doctor or a nurse really helps. It's more reassuring than a phone call. Video to care homes is something that is really moving on. You've got a patient in a care home, you've got maybe a nurse or a care assistant, and they can Zoom you in or beam you in to actually consult with the patient there. And also, if we get to the situation where a very high proportion of the workforce is off sick in one locality, it might be possible for people in another locality to provide remote support. The non-COVID related consultations, I think you can probably work this out. There's a lot of the chronic disease checks. I've seen specialists, asthma nurses, for example, do inhaler technique, peak flow readings, all sorts of things by video. So a lot of your diabetes, asthma, hypertension checks, especially if the patient's got the kit at home. Patients who need to speak to someone for administrative reasons, well, usually you don't even need to contact the surgery for a sick note now. It shows how fast things are moving. They can get that from NHS 111 now, but and likewise repeat medication, most of them won't need to. But if they need to talk to someone about it, counselling, as I said, you can see, and there's a trade-off, of course. You might have someone who's really quite unwell, but you don't want to bring them to the surgery. You don't want to go and see them in case you pass on something that you're incubating, and then you've really got to sort of balance the benefits and the potential harms. Inappropriately, now this is on the basis of research that we and others have done. Most of the research on video is on patients with chronic stable conditions. So of course anything that's serious, high risk, it's not recommended to use video. On the other hand, we're in very well, unprecedented clinical circumstances now. If the patient needs an internal, obviously this is all about the balance between risk and benefit. Comorbidities affecting the patient's ability to use the technology, I'm sure that's pretty clear. Serious anxieties about the technology. You know, some people really are technophobic. The psychiatrists will tell us that, you know, if you've got someone who's paranoid or, you know, has a kind of good-going psychotic phase, they may well think there's something in the technology, and they don't really do very well on remote. Deaf and hard of hearing patients usually prefer video to the phone, but they may have one of those loops on their phone, you know, but if they ask for video, it may be because they're either lip reading or wanting to use the chat function. So how do you get going? Well, this is probably the biggest change in the organisation and delivery of primary care services since the NHS was set up. Suddenly people can't just walk in and ask to see their doctor. The whole business about total triage, but also consulting by video, it's got to happen quickly, it's got to happen very extensively. That is culturally, organisationally, operationally very, very hard. So here's how to get to first base, if you like, and I'm very conscious that I'm speaking to people who probably know as much about this as I do. You know your practice, you know what works in your practice, and I'm not trying to tell you your job. But for those who want to kind of, wouldn't say idiot guide, but you know what I mean, the first thing you need to do is get your heads together. You know, given what we're talking about with contagion, that's probably going to be video or virtual, it could even be by email, and just have a discussion. It might be the practice manager, one or two key clinicians, and a project manager or a member of the administrative staff who's going to be in charge of actually making this happen. Agree, broadly speaking, what kind of appointments you think would be appropriate by video, what hardware and software you're going to be using. This may be that there's a local CCG level decision already made. You may have something installed. I saw a note from a question from somebody, can we use Microsoft Teams? And an answer came back, well, that's not ideal, but it might do. Yes, they're trialling at Microsoft Teams, at Barts, for example. Anyway, whatever, have the conversation, make the decision, and then make sure the staff know about the plans. Now, I've put here, and their concerns are heard. This is absolutely crucial. Staff are going to be worried, and if you don't bring them on board, if you don't air their concerns, talk about them, discuss, apologise for the speed at which this is happening, then you're going to get sort of undercurrents of people not really wanting to come on board. So let's get all that out in the open. And then you need a link somewhere to a local technical support team, unless you've got a very good person locally. I can't tell you how to do that because these are all very local decisions and processes. Okay, so setting up the technology, and again, I'm not a geek, I'm not a technical person, but you definitely need a good internet connection, preferably fast broadband. There are other ways of doing it, I'm told. And then you need to install, obviously, your video call software, your webcam, your microphone, and then just check it all before you get going. People are saying, you know, check it with Mickey Mouse patients, that kind of thing. If you are working remotely, and many of you will be working remotely over the next few weeks, make sure that you've got a reasonable level of home technology and that you've got read and write access to the clinical record system. If you haven't, that could be very problematic. And start to develop information for patients on what technology they are going to need to connect to you. Make that short if you can, because the patients are going to be very put off if you provide them these. I saw a 6-page guide the other day. They really only want 1 page. Okay, then you've got to set up your workflows. Remember, this is not just about implementing technology. It is about changing administrative pathways and workflows. And it's the workflows that are the difficult bit, not just connecting. That's why it's very easy to put Skype on your mobile phone and Skype your friends or WhatsApp or whatever, but it's very hard to get this going in the practice. It's because you need to change the workflows. So one of the things you need to do first off is make sure the information is on your practice website, saying this is how the video calls are going to happen. Update your clinic templates. Again, you'll be able to tell me how to do that. I don't know. Create an appointment code for a video consultation. And someone said to me today, create a code for video consultation in the midst of the COVID crisis, so that when you go back in 2 years' time, you can remember why this might not have been the most perfect time for doing a video consultation. Then you've got to put your processes in place for your scheduled and unscheduled appointments. Minal sort of talked you through some of that. That's all going to change pretty rapidly. And some kind of arrangement for in-person contact. And again, I'm sure you're already on that with your sleeves rolled up. Make some contingency plan for what to do if the video link fails. And I can tell you that that happens not uncommonly when you're still on the learning curve. And the obvious one is you have this little thing where you take the patient's mobile number, or when you contact them, the first thing you do is ask them, can I just confirm that your phone number is still this? And then say quite early on, before you get started in the consultation, right, if this fails, we'll have one go to reconnect, and then I will just call you by phone. So you need to sort of process for that. So training and piloting, yeah, look, you've got to train people. It usually doesn't take very long, and the best way to learn is from somebody else who's already doing the same job, who you like, who's reasonably confident, what they call a super user. So if you've got one receptionist who really takes to it much better than the others, make sure that she or he is supported to kind of train their comrades, because they know the detail of the job they are doing better than you do, probably. Make sure everyone's got the kit in their rooms. One of the problems is that if we're all going to be doing video consultations, it's no good just having access to it in one room. So think about how many terminals and things you're going to need to set up your cameras and stuff. Then you make your dummy call with Mickey Mouse or that kind of thing. And then you test the whole process, including what you're going to write down on the patient's record. Okay, so that's training and piloting. So how do you do it? How do you go about it? Look, don't worry about it if you've not done it. If you look on Twitter, people who are sort of responding to the things that I've been saying on Twitter, there's quite a few people popping up saying, I did my first video surgery today, and it was so much easier than I thought it was going to be. Now, here's a few tips for how you do it. And I can tell you, after you've done your first surgery, you'll be fine. So the first thing is make sure that as far as you can assess in advance, a video consultation is going to be okay for this patient. Then you've got your private, well-lit room. This is for those of you who are consulting from home and you've got the kids sort of banging around in the background. You know, you've really got to make sure that you've got a bit of privacy. Obviously, take the patient's phone number. Ensure you've got access to their record, ideally on a second screen. It's so much easier if you're looking at the patient with one screen and their record on a second screen. It may not be possible, but if you can, that would be better. And then on the day before you start your video surgery, check it's all working. So starting the consultation, everybody's going to have a different way of getting hold of the patient, because these are going to be different depending on what hardware and software you're using. At the beginning of a video consultation, it's not really like a phone call. It's there is that bit of a bit like we had at the beginning here. You know, can you see me? Can you hear me? It doesn't sound very professional. It doesn't feel very professional. But don't worry, because we've demonstrated in our research that once you stop all that fiddling around, once you've got the connection, what almost always happens is that then usually the doctor and sometimes the patient says, right, I'm ready, let's go. And then everyone slips into consultation mode. So there's usually a bit of fiddling, and then it becomes professionalized, if you like. You enter the professional clinical space. It's a bit like shutting the door to the consulting room, and then you can just get cracking. So you could take verbal consent for a video consultation, but then I think in the current circumstances that is implicit. If you've got someone sitting with you, but they're not on camera, you must introduce them to the patient and ask the patient to do the same. People get quite concerned that there'll be, for example, a parent or a spouse in the room. So if you say, look, I'm on my own here, and could you just introduce me to anyone else who's in the room? Obviously, they're allowed to have them in the room, but you also have a right to know who's there. And then reassure the patient that this is going to be very, very similar to a standard consultation, you know, all that kind of thing. And then you just get on with it. And what we've demonstrated is once you get into this, the main phase of the consultation, it works exactly the same way as face-to-face. There may be a few glitches, you may lose a bit of sound and have to, you know, adjust things, but that we've shown that that doesn't really make a lot of difference unless it is a big disaster like, you know, cutting out. Even if it freezes, it doesn't really matter because it'll probably come back in a few seconds. So I wouldn't worry too much about that. You don't need to look at the camera. You can just look at the patient's face on the screen. You don't need to look at the little dot in the top corner. It does help if you inform the patient if you're going to turn around to make notes or read from another screen, because then they feel that they can't really see the rest of you. They can only see your face. So if you explain that, you make your standard written records, that's probably obvious. Be aware that the patient is struggling as well. You know, you might have done 20 of these, but this is their first one. And then call them back if there's a problem. Closing the consultation, this is quite important. One of the things we've found with patients is that they often, not often, but sometimes say, well, the doctor just hung up on me. You do have to do the kind of ritualistic equivalent of walking them to the door, opening the door and saying goodbye. So give them a bit of a summary and possibly ask them to repeat something back to you, all the check back stuff. Ask them if they're happy to use the video again, and then do this ritual of, right, I'm going to close the call now, we'll both say goodbye, and then I will just ring off and I'll disappear from your screen, something like that. And then that sort of is just a little social nicety that I think we've all got to perfect. Okay, so what about the tips for patients? The first thing is probably to discourage most of them from needing the video, because it is so much easier to do just an online or a phone one. So make sure that they are directed to either the website or to a telephone consultation, but they might actually, it might help to tell the patients if they're highly anxious that they might prefer or might be allocated a video consultation, and that might help them. I mean, they'll know they're anxious. And the other reason is that if they need to know that you might be self-isolating. They may not have worked that out, so that can go in your information leaflet. And then some instructions for how they could get set up. These are quite similar. to the ones for you, I suppose. So, you know, a quiet place. They may need to be told that they've got to go into a room and shut the door. And then they really don't need very much beyond their smartphone, to be honest. They do need to test their audio and video. They do need to charge up, plug it in, remember their password to get into their machine, all that kind of thing. The rest will be on your practice website. They need to know that different platforms have different setup arrangements. So patients make a video appointment by following the instructions on the website. It may be that they can just click a button and get straight into a virtual waiting room. This is what the Scots use, and it really is marvellous for the patients, because then they just sit there listening to a bit of music until you pop up on the other side. But you know, depending, there will be an arrangement. They need to know what it is. So they click connection, and then they also need to be told what to do when they see your face, because they might be scared of you. They might sort of think, well, goodness me, doctor's seeing me in my living room, all that kind of thing. So it helps in your instructions to tell the patient to do something like wave or say hello so that you can check the sound, and obviously give their phone number. And then for the how the patient does the consultation, and you can see it's the same instructions that I've just given you, so I won't go through those again. One thing, if you look at number 17, they can actually use the screen camera to show things. We've done some work on patients with heart failure, how they sort of put the iPad down to show the ankle edema and things like that. They need to know what to do if they get cut off. The world won't end, you know, we'll make it all right again. Encourage them to write down advice or instructions. You can probably send them an electronic advice sheet. And then they also need to know that the doctor's not going to be offended if they disconnect a bit abruptly at the end. That might worry some patients. I think that's the end of mine. Oh no, yeah, there's the research literature. I'll just give you a brief, this is all I'm going to tell you about the research literature. Almost all of the randomized trials that have been done in low-risk patients, which is largely irrelevant to what we're looking at now. Very limited research on the use of video consulting in primary care. Brian McKinstry's done something in Scotland, but really not much. And almost none in acute epidemic situations. Our qualitative research shows that introducing video consultations is very challenging culturally and operationally, and it really helps to frame this as a service improvement initiative rather than an installing new technology initiative. Things just happen much more easily if everybody knows it's all service change. As I say, the technical connection is good. It unfolds very straightforwardly. Major breakdowns are embarrassing all round. It's possible, though not ideal, to conduct limited physical examinations by video links. I'm doing a lot of research on the hop at the moment on what exactly you can assess by video. And finally, and encouragingly, the Australians have shown us from their bushfire disasters that it is possible to get things up and running at scale very quickly in an emergency, but only if you've got man and woman power and extra resource, because this takes time and it takes money as well. I think that is the end of mine. Yes, so those are all the people who are sponsoring and funding us. Health Foundation in particular have been very helpful in the last week.
Thank you very much for that, Trish. I'd just like to let all our participants know today that we do apologise. We know we are now running over time. Obviously, there's a lot of good information to cover here, and we would like to continue slightly over time. We understand, however, if you do need to go, so please be reassured that the webinar recording and slides will be made available within the next 24 hours. However, we'd like to continue now with Dr. Robert Varnum.
Thank you, Natalie. Hello, everyone. I'm going to give a very brief piece of information about some of the support that is now going to be made available for practices to go through some of the process changes that people have been talking about so far. There's obviously a lot of support going to be available from technical experts, regional teams and local teams, and to learn from people who've already done it, what they've done. The Time for Care programme is about helping practices and PCNs with the yes but how, with the process changes, the reorganising your systems, helping the team be on board with change. About half of the country, half the practices in the country already know the Time for Care programme because you've already been part of it. And we want to let you know two things tonight. The first thing is that we're going to be repurposing the Time for Care support, the Time for Care team, to come alongside and help through COVID-19 with all the process changes that you need to make happen. Sometimes you can go through a really smooth and ordered process of changing things in the practice. I think many of us have found that actually we've just jumped in at the deep end with almost no planning, and now we're trying to troubleshoot and make things happen. Whatever your state of play at the moment, we are going to be making the Time for Care team available to help you. And the kind of things which we think are going to be most relevant for practices from what we've been hearing so far are listed on the screen here. So the whole tonight's topic, remote consultations using the phone, online working, video working, other aspects of new systems and pathways, new requirements for patient care, the challenges mentioned earlier with changes in demand and capacity, some of the reprioritization of our resources that we're having to go through at breakneck speed, and that challenge for practice managers and senior clinicians of leading the team through times of high challenge and fast-paced change. It doesn't just happen, as Tricia was saying there, it does take improvement processes and leadership. If you would be interested as your practice in receiving support with that kind of challenge right now, then use this link at the bottom and our team will be in touch very soon, like literally in the next 2 or 3 days. It's bit.ly/Time for Care COVID. That will come through to the Time for Care team and we will start collecting responses about ways we can help you. We're going to be responsive about that and wrap that support around where you are now rather than imposing a particular process or program on you. That's free. It's funded by NHS England and NHS Improvement. If you don't know about the Time for Care team, I'd suggest Google Time for Care. You'll see about who the people are and the kind of support and the feedback from practices over the last few years who've had support from us already. That's all from me because we want to be really quick. Lots more information if you put your expression of interest in, you're not committing to anything, but we will get back to you and tell you more and find out more about what would help you. Back to you, Natalie.
Thanks, Robert. I think we've lost Natalie. So I'm going to now go to our panel. So perhaps I'll just start off by asking the panel for some of their top tips around consulting online. So if I come straight to you, Ross, first, if that's okay.
My top tips really are, number one is to remember that it's a new form of consultation that you've not done before, and as a GP, it's a bit like when you first did a telephone consultation when you were a registrar. It would have been unfamiliar to you because you would have done most of your medical training face-to-face. So it will naturally feel higher risk, but it actually isn't. It's actually lower risk in my view, mainly because you've got a structured history up front. So the patient has spent their time putting those important bits of information there for you to gather. A lot of them had red flags, and so you have to sort of trust the system. You know, they've all been through a very robust process to make sure that they're safe, and so you've got to trust that it's going to divert those patients that need to be diverted. Because of our sort of training from the very early days of asking open questions, right from when we started at med school, and you have to kind of flip it on your head. And I often use the phrase that Yoda did from Star Wars, which is you must unlearn what you have learned. And that's because you actually really need to start with a closed question, which goes against every instinct of a doctor. because actually most of that information is already there. And the commonest thing that I see people do is they recollect the history. Whether that, so if you're contacting a patient via telephone or video and you've already had them through an online consultation system, the history is already there. There's no need to recollect it. Get right down to the business of asking a closed question or formulating a management plan. So the time to use video, I would say, is to think of it a bit like a stethoscope, and same with a telephone call. A lot of stuff you can close off remotely without with a message. And what you'll find is when you first start, you'll want to call everybody in. Then you'll go to calling everybody because you feel a lot more comfortable with that, or videoing them, or video calling them, sorry. And then actually you'll get much more comfortable with sending messages to patients. And I've seen that through every single person that I've trained in online consultation. I run an eHub, which is a centralized service of processing online consultations, and we close around about 85% of them completely remotely at first contact. So if you get the training right and trust the system, you'll find that you'll close a lot more remotely.
Thank you, Ross. Ed, could I come to you?
Hi there, hopefully people can hear me now.
We can, Ed.
Yes.
Great. Sorry, was there a question for me?
Oh yes, sorry, your top training tips on how do you consult online? What are your tips?
It's actually quite a new thing for me, really, because my practice is still in the process of deploying this, which is a bit ironic. So actually, I would go with the advice from someone like Ross there. I think that's very strong advice. I think what we've seen in practices as they've got used to this process is that it's often treated as telephone triage. So rather than being online triage, they're just reverting to telephone triage, which is an older model, and they're just treating that online consultation as a request for a telephone call. And as Ross says, often the clinicians will just retake the history. But the other downsides of treating a telephone triage are you miss that ability to resolve a lot of requests online. So the evidence from Ask My GP is with total online triage, you can deal with about 1/4 of requests completely online. And I think with the eHub, it's often higher than that, slightly different profile of requests there. And often those online messages are a lot quicker than doing a phone call because you don't have to do the whole sort of, oh, who are you, getting through on the phone and so on, doing the small talk. And the other thing you miss out is the ability to quickly identify that something is definitely going to be a face-to-face consultation. Now, that's not so relevant in the times we're in now, but in normal times, about a third or more will have to be face-to-face, and often you can see that from the online consultation. It's a bit of a waste of time trying to phone them when you know that you're going to have to bring them in. You've got to sort of play the probabilities here. And I think another thing is thinking about continuity of care. One aspect of that is if you've got one person doing the triage and the other doctors who have a booked-in face-to-face clinic, often booked in by the person doing the triage, then you often end up retaking the history. So you might spend a few minutes as the triage doctor trying to deal with something on the phone and then realise it needs to be face-to-face, and then you pass it on to someone else. And as Ross says, we're all guilty of sort of retaking the history when we don't need to. So that wastes time. Also, I think it's important to identify is there a best clinician to be dealing with this? And there were some slides, I don't know if we got onto those, about identifying who really needs continuity of care, and there are lots of ways being developed to doing that, to focus continuity of care on those who need it, so getting those patients triaged and seen if appropriate by their usual clinician.
Thanks, Ed. I'm going to come to you now, Dave. So we've seen a few questions around, are online consultations safe?
Evening, yes. I'd absolutely say that they are safe. This is, in many respects, much like Ross said, I think they're actually safer than doing things in an old way of doing them. So this allows multiple different layers of safety. So there will be some things that are absolutely easy to deal with as a remote consultation. So there'll be very clear things that are just quite safe to manage, be it a small request for information, etc. But we have a fallback of going on to telephone. As Tricia said, we also have video consultations for appointment appointments when we're not too sure if you do actually need any sort of physical check over patients. Then, of course, finally, although clearly we're all trying to reduce it in this day and age, the actual hands-on face-to-face consultation. I certainly comment from, I think I've been doing online consulting for 2 years now, something like 6,000 to 7,000 consults a year. And in fact, our safety has improved. So the reason why safety has improved is because the workflow redesign that online has allowed us to do has sped up response times from GPs. We've had more time with people when we have needed to spend time with them. So it's a different tool set for what we need, and certainly at this moment, I think it's the right tool set, so we can operate in a much safer way rather than trying to manage everything either on the phone or with a face-to-face consultation, which is really suboptimal in the current climate.
Thanks, Dave. So Trish, I'm going to come to you now.
Okay, yeah.
There was a question around remote assessment of breathlessness and the usefulness of the Roth score. Now, I know you've been doing some work around that, so would you be able to share?
Yeah. So actually, I mean, those of you who follow me on Twitter, I've been posting a sort of update. I got quite excited about the Roth score because it came up when we did a rapid review. So just to bring up to speed people who don't know what the Roth score is, you would be forgiven for having never heard of it because most respiratory physicians haven't heard of it either. But, you know, one of my PhD students actually discovered it. It's a very simple score. It's not really a score. It's a timed, so you tell the patient to take a deep breath and then start with number 1 in their native language and just keep counting until they get to about 30. Now, what you're timing is the number of seconds until they take a breath. And actually, someone said to me, why don't you just get them to say their mobile phone number? That's what she said she did. This was somebody who assesses breathlessness over the phone. So they have to say something. And in the Roth test, they say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. When they take the breath, that's the time it takes. It doesn't matter what number they get up to, obviously, because different people speak at different paces. If they are less than 8 seconds, that has about an 80% sensitivity of picking up an oxygen saturation of 95%. And if they're less than 7 seconds, it's got a 91% sensitivity. The problem with it is it's based on a single small study in a hospital population and healthy volunteers involving about 150 people. So it's not a very big study. It seems to have been done reasonably well, but these are patients who are sort of lying in hospital beds, not anxious on the phone. So there's no telephone element to it. Now, because that was the only study about assessing breathlessness, you know, in sort of verbally, all the other ones are made for sort of assessment of chronic breathlessness, like the MRC score, and it's really not about acute breathlessness. So we had a look at those. Anyway, so we decided that we would do a survey of expert opinion. So we surveyed a total of now 56 people whose job it is to assess breathlessness over the phone. Mostly doctors, also nurses, a couple of respiratory physios, and we gave them the Roth score and we asked them what they thought of it. And it was very interesting. About 40% of them, most of them said they'd never heard of it or they didn't use it. About 7 or 8 of them used it as part of a wider clinical assessment. So about 40% of them said they thought it would add to the clinical assessment, and 60% of them said that they didn't think it would add. And one of the questions we asked them was, do you think this test could cause harm? Very important, of course, because a diagnostic test can cause benefit and harm. Now, the reason why they thought that it might cause harm is that assessing someone over the phone, they reckon the best data you got was from having a conversation with the patient, a sort of natural conversation, like, hello, how are you, how's your husband, you know, those kind of things that we ask as GPs, and listening to whether the patient is distressed, whether they're struggling to catch their breath when they're just having a simple conversation with you. And actually, given that they're probably quite anxious and what they want to do is talk to you rather than you give them tests to do, I can well sympathise with the experts who say this ROF score is not going to fit naturally into that kind of telephone consultation. But the other reason why they thought it might cause harm is that although it's quite sensitive, it's probably not very specific. And so what would then happen is a lot of patients might get called to be seen in the surgery or for a home visit when they wouldn't otherwise be summoned to do that. And so you'll be exposing those patients to the risk of contagion unnecessarily. So we decided in the end that we wouldn't recommend it, but that was actually after we put it out on Twitter as a potential solution. So it's not that we're saying it's a bad test, it's that we're saying a test that hasn't been validated or assessed context of what we've got going now. But currently, what we're using is the 3 questions that get asked by NHS 111, and I can't remember what they are, but I've got them somewhere. I've got them in front of me now. Well, there's the open-ended question, how is your breathing today? Then these are the NHS 111 questions. Are you so breathless that you're unable to speak more than a few words? Are you breathing harder and faster than usual when you're not doing anything at all? And are you so ill that you stop doing all of your usual daily activities? So those are the NHS 111 questions. And then the other thing that the experts said is focus on change, focus on the story of deterioration, because actually some people have been breathless since 1989, and it doesn't seem to cause them much trouble. It's worse this afternoon than it was this morning. Those kind of stories. And finally, what the experts said is you've got to interpret the breathlessness in the context of the wider history and physical signs. So, for example, if someone else on the phone is saying, look, my husband's gone blue, and then you talk to the patient and they sound breathless, that's far more significant than if they haven't gone blue, or if someone hasn't described them as going blue. So you see what I mean? So they're very keen on holistic assessment. Anyway, the whole of that will be up very soon on the Oxford EBM website as a rapid review of the assessment of breathlessness. It will also be in the BMJ tomorrow, where I've got a 10-minute consultation coming out, how to assess a patient by video or phone on Query COVID.
Thanks, Trish. Okay, so just a last couple of questions. So if I go back to you, Ross, what happens if an online consultation is sent overnight and there's something urgent in it?
Some kind of triggering mechanism that will pick out patients that are high risk and will essentially direct them that this isn't appropriate for them. Most of the sort of algorithms that are there are designed for those kind of minor illnesses that can be dealt with within primary care, and as I say, trigger out those that are not appropriate at that time. The ones which are perfectly fine and are minor will be told a response time, depending on what system it is and how it's set up, as to when they will be responded to. So it's pretty straightforward, and that's why they've got those safety mechanisms there.
Brilliant, thank you. And then Dave, a question to you around demand. So do online consultations or digital access lead to supply-led demand?
Yeah, really good question, the one that I'm always asked, and clearly we're slightly in uncharted waters at the moment about what the public are going to do, but up until this point, there's been no increase in demand to practices that have moved to a total triage, certainly digital-led model. So that's with data now from hundreds of thousands of consultations. You may see, when you first open up these pathways, that your total number of consultations increases, but do remember, it's not actually face-to-face consultations you're having. So when we've measured time spent doing all these consultations, our own time in practice has actually dropped a little bit in terms of time spent consulting, but we've actually helped more people.
Thank you. So I think, for the sake of time, we'll close the webinar here. We'll record Ed talk through the calculator, so it's there for people to watch back through. Ed, I hope you don't mind. But thank you very much, and thank you for your patience and bearing with us for an extra half an hour. Really appreciate it. Natalie, handing back over to you.
Thank you, Minal. I'd like to end this webinar by thanking all our speakers that we had today for giving up their time and coming and sharing their expertise with us. I'd like to reiterate a thank you to those of you that attended the webinar today. Just a reminder, we will be making the webinar recording and slides available on our future NHS workspace called Digital Primary Care. You can see it up on the screen now. If you don't have access to this or can't find it for whatever reason, please do email us using england.digitalfirstprimarycare@nhs.net. That concludes today's webinar. Thank you once again.